Good afternoon, everyone. My name is Olle Ljungqvist, and it's a pleasure for me, alongside my partner in crime, Ken Fearon from Scotland, to bid you welcome to the second World Congress of ERAS. It is really a pleasure to see so many of you here. We had a dream of doubling up the number of attendees from last year, or last time, and we were a little over 200 that time. We're 450 almost this time, so fantastic. Great of you to show up. But I think you're here for a good reason. You are in for a really, really good program with a lot of the top-notch speakers from around the world sharing the very newest in this field. So what's ERAS Society?
Well, ERAS Society started a while ago as the ERAS study group, and this was 5 surgeons from Northern Europe wanting to put nutrition and metabolism back into mainline surgical practice. We initiated our group in 2001. We produced our first protocol in 2005, and we revised that protocol in 2009. And you get a feeling for where we were positioned from the map. This is the core of the ERAS protocol we developed and published in 2005, and this has been one of the most reproduced figures about enhanced recovery published in the literature so far. And it remains at this core idea of a multidisciplinary, multi-faceted approach to optimizing patient care. We then decided that this was for real, it was taking off, and the evidence of this Congress is part of the importance that the healthcare community has placed on enhanced recovery. So we decided to found this society with the mission of developing perioperative care and improving recovery through research and education, but also importantly, audit and a robust implementation of evidence-based practice. And this is where the focus is at the cutting edge. Are you doing what you think you're doing? And do you know that you're doing what you're doing? And it's only then that you can really say you have implemented the evidence base and that you can get optimal results for your patients. To facilitate the dissemination of current knowledge, we have developed a formal guideline process, and 3 new guidelines were published in 2012 on colon, pancreas and rectal resection. We have a new guideline on cystectomy published in 2013, and we have a whole raft of further guidelines covering orthopedics, gynecology, all sorts of different subjects in preparation just now. And all the current guidelines and the future guidelines will be available free on our website. And I hope everyone in this Congress tries to visit the ERAS website, if not during the Congress, when you get home, because it's full of good information.
Well, actually, all of you have received this little memory stick in your bags, and the guidelines are right there if you haven't found them on the net. Well, it's fine and dandy to put together guidelines, but it's even better if they work. And one that actually did test that was Ulf Gustafsson, and I'd like to show you his data from a few years back. This is on colorectal cancer, and what it shows is that with higher levels of compliance, if you move from left to right, you actually get shorter length of stay for these patients, and you also have fewer readmissions, not more. That was some of the criticism early on. Well, that's nice and dandy for economics and for hospital beds, but what is even more important for the patients is that complications also come down. There's one presentation here from St. Mark's that will show that this actually holds up on a multi-center situation as well. So that's something to look for during the conference. And in fact, if we look at the database, you can see the same kind of graph here with the length of stay versus the compliance, and now we have about 1,000 patients in different hospitals where each dot shows the individual hospital. And you can see the curve looks very familiar again. And like Ken was saying, we have several of these guidelines are out already. Anesthesia has just been submitted, 2 papers, and there's a whole range of guidelines. And I will introduce some of the leads to these guidelines to you as we move along a little bit later, so you know who to contact for your specialty. We also move into helping people actually put this into practice with the implementation program. And the strategy that we've been using is that we set up a center of excellence that formally uses the systems and the way that we are doing things, and then also achieve good results. They present themselves and what their idea is, which is to invite a lot of other units to come and understand what enhanced recovery is all about, and then they invite them to an implementation program, often for colorectal, but it's also been done in other disciplines, and that's how these things are being spread. This is from our Swiss colleagues in Lausanne and their training program. You can see here to the left where compliance with the protocol goes up, again the length of stay slowly comes down there. So it does work in this kind of setting for many hospitals as well. This is 600 patients roughly on these graphs. So if we just go back to when we had our last conference in 2012, we had a few centers around the world. Implementation had just started. Denmark was clearly ahead of a lot of us. We had just started a little bit in Sweden. Holland had some good experiences at that time. Today, we can see that only 18 months later, things have grown a lot. So we have several of these programs now going in different countries, more centers starting up. So it's growing fast, but the slide also shows there's still a lot to be done. And this is where we have our mission, all of us in this room. So if we just look at the database, that mostly colorectal patients, but we have about 11,000 patients in this database, and this is something that is now becoming very useful for our efforts in developing things further. So we of course have a research agenda. So for each domain of surgery, not only colorectal obviously, but we're now starting to collect data in cystectomy and other domains as well, to do the audit research, to check whether how these guidelines actually work and which elements are most important. But it's also made for prospective trials. We're finally in the process of starting to test that. Will happen later this year. Of course, with these kind of instruments at hand, we want to make it open for people to come in, and those who are putting data into the system should also be available and eligible to study that. So we're setting up a committee who will help organize all of that and make it very public what is ongoing. So this will be initiated later this year. Another very important aspect is the website, and a lot of things are happening on that website, developing continuously. Just to give you the current situation, with almost 5,000 users last month and 24,000 pages being looked at, interestingly enough, we're attracting a lot of new visitors also. 38% are new visitors, so that is really encouraging. Traffic has increased, as you can see here. 35% since just a few months ago, and 100% since 2012. And it's worldwide, it really is. You can see there's a lot of interest in North America now, but also in Europe and in many other places around the world, which is also very encouraging to see. You can register as a user on the website, and this is the evolution of registrations, and please feel free to do that. That will help us reach you with information as they come along. A very interesting and important new development is the nursing group that have just started. And that's been run by Dorte Hjort with help from several of our colleagues, as you can see here on the slide. And they have their own section now on the website. And that is something that we are going to develop for all the different domains of surgery as well. And this will give you examples of patient information that have been developed so you don't have to reinvent the wheel. And some of these things are really outstanding, so take a look at them. Also, care plans and pathways so that you can see how people have been building these things before. And references, not least, specifically targeted at nursing. And I'd like to just mention a message from Dorte. There will be a meeting for the nurses downstairs in the lunchroom at 6 o'clock tonight for those who would like to attend. And I think this is a true sign of our multi-professionalism in this society. Well, you're all welcome. This is Dorte, so you will recognize her. And you know, behind every great woman, there's also a man. So, of course, Henry Kellett is our honorary member here, and we have the lecture in his name. He's the forefather of all of this. He started Fast Track, which was the thing that got it all going, world-renowned. Of course, we will hear more from him, but also about him at the lecture tomorrow.
Thanks, Holly. So the next thing to just briefly review is the growth of the scientific basis of enhanced recovery. And this was a survey we did just a few days ago, looking at publications on enhanced recovery in PubMed. And you can see since its inception in 2005, we've seen a progressive growth in publications with 66 individual publications last year and a likely target greater than 80 this year. So there are now 200 peer-reviewed publications out there on enhanced recovery in the literature for us to refer to. And when we look at the evolution of the domains that have been covered by these publications, we see that initially they focused on colon and rectum, which was really the domain which Henrik had focused on to outline the original principles of enhanced recovery. But then it spread to cardiovascular, bladder, liver, pancreas, and so on. Interestingly, orthopedics with hip and knee replacement appearing under the enhanced recovery banner in 2011, and the first publication on emergency patients being managed within an ERAS protocol coming for under fractured femur in 2012. And I think that this is a very exciting area for ERAS to be expanding into, is not only elective surgical practice, but also emergency issues. And with that theme, we see that in 2013, that slightly, if not emergency, urgent issues such as caesarean section have been brought up within enhanced recovery pathways, pediatric surgical practice, small bowel resection for Crohn's disease, and interestingly, donor nephrectomy. So it's evident from the literature that enhanced recovery is spreading throughout the entirety of surgical practice, and I think that's very encouraging. Equally, if we look at the individual topics that have been covered in the literature, we see back in 2005 our original protocol, then subsequent publications covered the implementation of this protocol, and that a protocol was not enough. You have to have an implementation process to make it work. Then this holy grail of enhanced recovery, the fact that we're not primarily focusing on length of stay, but the quality of recovery of the patients. And the first meta-analysis published suggesting that, in fact, following this enhanced recovery process led to a reduction in complications, a very important message then as in now. Then, following that, we saw people beginning to say, well, can we tinker with this protocol? Are there things that we can change and optimize? And the question of the use of drugs to improve gut function, and also the question of inventing a medical epidural rather than the classic epidural that we have been used to. Equally, we saw the maturation of the enhanced recovery pathway with the nursing community grasping these important issues of, well, what is the role of the nurses? How do we improve implementation of the enhanced recovery pathway? And in terms of nursing care, very importantly, beginning to ask for patient feedback. And these are issues that I think you'll find are debated actively at this conference. Again, we then see in 2012-2013 people saying, well, which elements determine outcome from an enhanced recovery protocol? Should all patients go into an enhanced recovery pathway, or should we actually select different types of patients for different recovery solutions? And these are, again, questions that we have not resolved, but are very exciting issues to tackle. Should we, the original work on Fast Track emphasised the benefits of epidural anaesthesia and analgesia. But again, we have seen a maturation of the process, the development of minimal access surgical technique, and then the question of, well, do we need an epidural for every patient to recover at optimal speed? And in fact, the Cochrane guidelines last year suggesting, in fact, that an epidural was not required for patients undergoing at least laparoscopic colorectal surgery, colonic surgery. So we have an active scientific community out there constantly questioning not only the protocol itself, but the patients who should be included, where the focus should be, and what the elements of the protocol should be. And finally, I think very interestingly, I think in the literature we've seen the first evidence of long-term benefits of enhanced recovery, with the publication of a paper suggesting that if you have your hip or knee replaced on an enhanced recovery pathway, then your mortality is significantly lower at 2 years. So I think that's a very exciting area for ERAS to be thinking about. What are the oncological sequelae of being managed within an enhanced recovery pathway, and what are the survival benefits in the longer term?
Yeah, so we just looked at the registrations to let you know who is actually here. We got Colin, no, we won't do everyone. So actually 250 doctors, 66 nurses, dietitians, students, exhibitors, and so forth, 238 compared to 202 last time. So I think that's really great to see. We had 111 participants to the introductory course. We're here from 38 countries, from 6 continents, and that's also says something. The top countries are Spain. Thank you, Jose, and your team. This is moving by itself now. You see United Kingdom, Sweden, Switzerland, and the US. We have 110 abstracts, so that's on the other side of that wall, the room just beside us. We have the abstracts. Please go and see that. And then I come to some of the highlights, and I got to give you a bad news and 2 good news, 2 pieces of good news. The bad news is that one of our main speakers, Tony Senegor, called in sick yesterday. He was hospitalized. Fortunately, he's fine. So he recovered, but there was no way that he could travel. So that is really the sad news. Our hearts are with him, and we hope to bring him in another time. The good news is obviously that he's feeling better. And the other good news is that that gave us the opportunity to ask Franco Carli to give the Henrik Kell lecture. And he's a very, very worthy man of that talk. So he will give us the title From Fast Track to ERAS, A Metabolic Journey tomorrow instead of Tony. Thank you, Franco. The other main lecture is Stanton Newman from England, and he will talk about measuring cognition after surgery and anesthesia, a very hot topic. You will hear more about that as we move along. We have the best abstracts and posters. They will be following the main lecture, so those are also the highlights of the news at this meeting, best scored from the scoring and the abstracts. And all the news, obviously, for all the abstracts. And don't forget to go to and visit all the industries out here, because they have brought a lot of interesting news as well for us to look at. So take that opportunity. And I'd like to, at this time, also thank our sponsors for their fine contributions for this meeting. The other thing that I'd like to introduce is, I'd like to introduce a series of colleagues who are leading groups of specialties. So Yannick Serrantola from Switzerland, if you're interested in urology, this is your man. Tim Batchelor from the UK for thoracic surgery, he's leading that group. Gynecology, unfortunately Greg is not here, but there's a lot of gynecologists here as well, so that's another group that's being formed. Pancreas, Christopher Lassen, well-known guy, even if the picture wasn't the best, maybe. It was taken late last night. Of course, we have a lot of anesthetists here. Three of the leading guys here, Arne Feldheiser from Germany, Mike Scott from England, Franco Carli from Canada, and the newcomer, Gabriele Baldini, who has done a lot of fine work for the guidelines. He's one that you definitely should meet as well. We have a group starting up with orthopedics, Tom Wainwright from the UK, and of course, a lot of people here interested in colorectal. You can see a lot of faces in there, and trying to hide is Ulf Gustafsson, and on the other side you see Jonas Nygren, who were the leads for the guidelines last time. So, with that, I bid you, along with Ken, very welcome. This is the opportunity to meet new people, old friends, enjoy, share, discuss, and develop enhanced recovery all jointly together. So, heartily welcome. It's going to be a pleasure to see you all here and enjoy it. Thank you.